This podcast will supplement both lecture and lab material as it pertains to clinical management for a patient with multiple sclerosis. This podcast specifically will focus on the examination aspects for this particular patient population. Please note that as we move through the various standardized outcome measures that are included within this narrated PowerPoint, that the blank score sheets for 3 of the tools are posted on Blackboard. And then the longer tool pertaining to quality of life, the MSQOL 54, is also on Blackboard for you in its full format if you're interested in looking at that tool in a bit more detail. The learning objectives listed here cover both Zoom sessions, and you'll see that they mirror pretty closely to the lecture learning objectives that you were provided with, but we'll have a bit of a more hands-on approach in the lab-based sessions, albeit remotely through Zoom. So from a learning objectives perspective, we'll talk about examination, and you'll be able to describe and demonstrate an understanding of how examination for patients with MS is unique to this diagnosis and what some of those potential key impairments may be. You'll also gain additional knowledge related to administration of standardized outcome measures, some of which are specific to MS and others which are recommended by the MS task force for students to be able to have an understanding of those tools. You'll be developing a session outcome for a paper-based patient to develop an intervention. And through there, we'll talk through intervention strategies as we build that together that would be appropriate to address those impairments for these patients, and then some unique aspects for these patients as it relates to how you're going to provide the intervention, how you're going to schedule rest, and so on and so forth. And then we'll lastly talk about other related aspects as it pertains to patient education regarding energy conservation and activity pacing, and any specific strategies that need to be addressed as it relates to handling and communication and therapeutic equipment. We'll begin our discussion here as it relates to the examination aspects. Of course, we'll start our examination with observation of function and the subjective history of our patient, and we'll follow that with a systems review. From there, we will select specific testing measures as it relates to that patient's presentation. I have listed here a good chunk of the tested measures that you would do with this patient population, but this certainly is not an all-inclusive list. On the right side of your slide are selected outcome measures that are recommended for patients with MS, and we've talked about the majority of these already, but we will go into detail in this lab as it pertains to the 12-item MS walking scale, the 9-hole peg test, and the River-Mead Functional Mobility Index. One point that we discussed in lecture, but is worth reiterating, is how important it is to be able to assess the patient in both a fresh and fatigued state. In patients with MS, we know that the fatigue will be quite variable, not only from day to day, but potentially from hour to hour. So if you examine a patient in a fresh state, you may have different results than if you were to repeat those same measures towards the end of your session. And that's because the patient will fatigue over time, and you'll pick up that aspect of fatigability that we discussed. So this is a concept that is being supported in more recent literature to really take a look at some of those functional skills or examination items while the patient is fresh, or when they come in to see you, but also when they're fatigued. We know that patients with MS are not going to spend all day, every day in what they would consider a fresh state. So it would not paint a really accurate picture if we only took a look at their performance in those rested states. So what we're really interested in is how does that change over time and how does that change with work? So you want to make sure to be able to assess when able in both of those conditions. This podcast is going to discuss 4 standardized outcome measures that we touched on in our lecture on patients with MS. We will review the 9-hole peg test, which certainly has indications for patient populations outside of just patients with MS, the 12-item MS walking scale, the Rivermead Mobility Index, which also has indications for patients other than those with MS, and then finally the Multiple Sclerosis Quality of Life tool. You will need to understand the basic constructs of these 4 standardized outcome measures, the information that each measure gives you, and why you might choose to select one or more of these specific standardized outcome measures. There are some questions that I'd like you to think about as you move through the remainder of the PowerPoint. What factors drive your clinical reasoning process when deciding what standardized outcome measures to select for a patient with multiple sclerosis? And what information do these tools give you, and how does it inform your plan of care for this patient population? And then as we move through these tools, I'd like you to think about the advantages or limitations of each of these tools. So the process that you go through in determining the selection of standardized outcome measures isn't any different than what you would do for any other patient population. You've completed your examination, and now you're looking to fill in perhaps gaps that you might have or gain a better understanding of certain areas based on your subjective and objective examination. The first standardized outcome measure that we'll discuss in this lab is the 9-hole peg test. You'll watch a video in a moment of Dr. Kelly performing this task per the instruction of Dr. Ingalls. You'll see that this is a timed test of motor performance of the upper extremity. So we're looking here at fine motor function, manual dexterity, and aspects related to coordination. So this would test at the activity level of the ICF. In terms of administration, it's a fairly quick administration, usually between 5 and 10 minutes, depending on the patient, to get them set up and complete the task. You're going to provide 2 trials per hand. You'll test both the dominant and the non-dominant hand, and you're looking to time you're looking to time how long it takes the patient to pick up the 9 pegs out of the well, place them in the holes in the board, and then remove them and put them back to their starting position. You're going to time that twice per hand, and then you average the 2 trials for the dominant hand and the 2 trials for the non-dominant hand. You compare that data to the norm referenced information that is available for this tool that's organized by gender and age. In terms of the MDIC, for patients with MS, research has established that a 20% change would be considered important in this patient population. When you think of the pros and cons for this specific tool, there are a lot of pros that have led to its frequent use in the evidence for patients with MS trying to examine fine motor, manual dexterity, and coordination of the upper extremity. It does assess at the activity level, so these are functional tasks or simulate functional tasks that the patient would be performing in their everyday life. You can also use this tool with a variety of patient abilities. So if you think back to that EDSS scale, this tool has good reliability and validity no matter where you're falling on that EDSS scale, from no or minimal disability up through severe disability. So for that reason, it's a pretty popular tool in the research as of late. Potential drawbacks to this tool really relate to being able to kind of learn the test. So it's not uncommon to see improved scores as the patients practice this test or have used this test more. So that would be a potential downfall in selection of this tool. The next standardized outcome we will review is the 12-item MS walking scale. As the name suggests, this tool was developed specifically for patients with MS. This is a self-report measure related to the impact of that patient's MS and the disease process on their walking ability over the past 2 weeks. So the patient is reporting their perceived challenges as it relates to function surrounding walking over the past couple of weeks. So this is looking at the activity level of the ICF. There's 12 items that the patient will assess, and we'll look more closely at that in the next slide. And they're going to provide a score for themselves ranging anywhere from 1 to 5. 1 is determined that their function hasn't been impacted at all as it relates to that criteria, and a rating of a 5 would stand for extreme limitation. Once the patient is done with this test, the scores are summed and an average percent is obtained. A lower score would indicate less impact of their MS over the past 2 weeks on their walking ability, and then a higher score would suggest that they've been more impaired by their MS as it relates to walking. The minimal detectable change for this tool would be a 22% change. So if you were to give this standardized outcome measure potentially at the beginning of your episode care and then check back, in 6 weeks or so, a 22% difference would be considered a minimal detectable change, or that we could be sure that the change in score was not due to chance. On this slide, we have the actual tool available so that you can see the 12 items that the patient is rating and the scale that's associated with those items. So as you can see, there are a lot of different aspects of walking that are taken into consideration, anywhere from doing activities in standing to be able to walk inside, walk outside, and then some of the quality pieces related to how smooth that is, dual task scenarios. So it does capture a variety of aspects that are related to walking. Next, we're going to move into some case-based application for the 12-item MS walking scale. I'm hopeful that this will give you a better idea of what the scale consists of and the changes that could be seen with a real-life application. So we're going to talk about Debbie. She is a patient who has been coming to ClinNext for quite a few years now in our program. She's currently 67, and she has a 29-year history of having MS. So she was diagnosed back in 1991 with relapsing remitting. At the time of diagnosis, she was a smoker and had smoked for quite some time, 28 years until 1998, at which point she decided to quit. She was smoking about 1 pack per day. She did use disease-modifying therapies, and that ranged from some of the sub-Q injections to some of those infusions and oral medications. from 1994 through 2017. And then she opted to stop using any of those medications in July of 2017. Just a little information on her relapse history. She had 6 relapses between 1991 and 2000, which required IV steroid therapy, but she really has not had any true exacerbations since that time in 2000. In 2018, she decided to consult with a nutritionalist, and she changed her eating habits fairly drastically and also increased her physical activity. So from the point prior to that, she was exercising and engaged in activity about 1 hour a week compared to the 6 hours a week that she was completing afterwards. And this resulted in her losing 40 pounds over the course of about 10 months that she's currently kept off to date. Her neurologist does classify her as having secondary progressive MS, which is pretty common given how long she's had MS for. The next slide has 4 video clips of Debbie. 2 of them are from 2017, and the other 2 were taken just last week by her daughter in her home. And I have clips from our patient demos that show Debbie walking and turning, as well as walking backwards. It's important to note that in 2017, she used a rolling walker as her primary means of functional mobility, and she also was wearing a left AFO. So the video is without her walker, but it's important for you to have that context that she did pretty much use a rolling walker for all ambulation in and outside of her home. The clip from 2020, she does not use a walker anymore, nor does she use the orthotic device. So I just wanted you to have that context before you watch the video. The reason I've included these videos is not because you need these videos for this specific tool, right? So we know that this tool is the patient's perception and a patient-rated score. But I wanted you to be able to paint a picture in your head of her functional mobility skills and make some comparisons between years, so that when you go to see her scores on the following slide, that might have a bit more meaning to you.
Walking without the walker. You let me know if you get.
I feel like I'm doing a moonwalk. Come on, Michael. Yeah. You're doing a good job. Trying to move my feet back. They're not going up. Okay.
Now that you have a picture in your head of what Deb was doing in 2017 compared to now in terms of some of those functional walking skills, let's take a look at how she rated her performance across years. So in this picture, the red represents 2017 and the blue represents current performance in 2020. So just looking straight off the bat, you can see that for the most part, save item number 2, her performance was rated worse or higher scored back in 2017. If you'll think back to the video you just watched, that makes good sense. So she did rate the running the same, and I think that's reasonable. That also is probably not an activity that she engaged in 3 years ago or is attempting to engage in now. But for the most part, we saw improvement of at least 1 point, anywhere from 1 to 3 points on her score between 2017 and 2020, which rendered her score an improvement of 40% across years. So recall from a few slides back that the minimal detectable change for this tool for patients with MS was established at 22%, so well over that established change. Let's talk about some of the pros and cons of this specific tool. I think some of the advantages is that, again, this tool is quick to administer, it would be inexpensive, and it does cover several different considerations as it relates to walking and environmental factors. So I think it does help create a wide snapshot of what the patient's ambulation abilities are. The drawbacks to using this tool, of course, is that it's self-report. So if the patient does not have an accurate perception, if their perception does not match what their functional mobility actually is, then that kind of negates the validity of their report. So that's certainly something to keep in mind. The other piece that's limiting is that because this is based on ambulation, you're not going to use this tool with somebody who is higher up on the EDSS scale. So potentially you'd think about using this tool for patients that are under a score of 8 that might have some mobility or some ability to stand. And then lastly, if you noticed, it said this tool directs you to rate your performance over the past 2 weeks. So with a patient with MS, that may or may not be an accurate representation of their disease process as a whole. A patient who's come off an exacerbation, that's not the time to give this specific tool if you're asking them to reflect back on the last 2 weeks, because it's going to make them seem more impaired in this area than potentially they really are. Or maybe that's your intention. So maybe you want to compare what an exacerbation is like versus when they have recovered from an exacerbation. So I think either is okay, but you just have to understand that going into it, that you're really probing over the past 2 weeks and that potentially has some disadvantages associated with it. Before I move on to the last standardized outcome measure that we'll talk about in this lab, I just wanted to take a few moments to make some links to lecture related to the patient with MS and some of those favorable versus unfavorable prognostic factors. So we had talked about being overweight or obesity as being an unfavorable prognostic factor as it relates to number one, being diagnosed with MS in the first place, but then also the number of relapses and the volume and number of the lesion loads that this individual may experience. We also talked about smoking as it related to increased likelihood of diagnosis and increased exacerbations once a patient is diagnosed. So Debbie is really a real life example of those modifiable factors. So if you noticed back in her history, she had a long-standing history of smoking, and the majority, all of her exacerbations actually occurred during the time that she was was smoking. And then shortly after she stopped smoking, she didn't really have any other exacerbations that required intervention from a steroid perspective. So that's interesting. And then you consider her weight loss. And she was certainly not obese prior to that weight loss, but the 40 pounds of weight loss could certainly put her in a more favorable prognostic category as it relates to level of inflammation circulating, exacerbations, and recovery. And then certainly just if you think from an energy conservation perspective, having 40 pounds of weight removed from you is certainly going to make for more efficient functioning and more conservation of energy, which is really what we're aiming to do with these patients. So I just wanted to make those links here because Debbie is a really great example of how modifying some of those factors that you can control in your life can be beneficial and really help you along, even though you have a disease process that's been labeled as progressive. And her category at this current moment is primary progressive, yet she's made huge functional gains over the past 3 years while she continues to age. So those prognostic factors are important, but a lot of them, as we talked about in lecture, are modifiable. So that's something to keep in mind as you begin working with these patients. The last standardized outcome measure we'll discuss for patients with MS is the Rivermead Mobility Index, or the RMI. This tool was originally developed for patients post-stroke or those with brain injury, and then was later used on patients with MS. This is a 15-item measure. 14 of those 15 items are patient self-report, and 1 item is performance-based. So if you scroll over to the right, you can see that the standing unsupported item, where you're going to observe the patient standing for 10 seconds without any aid, would be the performance-based item. And this tool measures at the activity level of the ICF. So you can see that the items there range from some bed mobility to standing balance, walking inside and outside, squatting and recovering an object up off the floor, some bathing, steps, and running. So it covers a wide variety of activity level on the ICF. The patient's going to rate their ability either as a 0, which means no, or a 1, that means yes. And after the patient is completed, you're going to add up those scores and determine where they fall relative to 0 being a lower performing score and 15 being a higher performing score. The minimal clinically important difference for this tool for patients with MS was established at 2 points. And more information on this tool can be found through that link, which will take you to the Shirley Ryan Lab. When thinking about the advantages and potential disadvantages with selecting this particular tool, I think, again, some advantages are that it does cover a wide range of mobility level activities, which then allows you to be able to use this with patients at any point on the EDSS scale. So there are some items that even if they weren't ambulating, they might be able to participate in. So I think that would be a positive. This is also a quick tool, an inexpensive tool to administer, and of course easy to score. From a disadvantage perspective, again, most of this is the patient's perception of their abilities, so that may or may not be accurate. The last tool that we will discuss is the Multiple Sclerosis Quality of Life, or the MSQOL-54. The MSQOL-54 is a structured self-report questionnaire that gauges the patient's perceived quality of life. It is made up of 54 items, and this tool was derived by taking the SF-36 and adding 18 MS-specific items to the tool to arrive at the 54 items. The items on the tool measure the patient's activity level of the ICF. You can see the subscales over to the right, and it really does gauge a wide range of quality of life issues. The tool will probe about physical function, any limitations that the patient may have, either physically or emotionally. It will discuss pain, energy level, their perception of their own health, as well as other areas such as social and cognitive function and sexual function. There are a few items that probe into the overall quality of life of the patient as well. When administering this tool, it is relatively quick. You can assist the patient in the interview process, or they can complete the tool on their own. The tool usually takes between 10 to 15 minutes to administer. And when you're scoring the tool, you don't arrive at a single score, but you will get 2 different combined scores, one being the mental health composite and one being the physical health composite. The main advantage to using the MS-QOL-54 is that it's really easy to administer. As I said, it's a short administration time, and it can either be administered in an interview process or the patient can score themselves out. It also covers a broad range of health-related quality of life issues, so it really gives a very well-rounded look of quality of life for a patient with MS. The disadvantage to this tool is that because it covers so many different domains, it doesn't really get very in-depth on any one specific domain. So it's not going to really drill down into social function or cognitive function to the extent that you might want it to, because it's more of a broad range tool that looks at a variety of subscales. As you're reviewing the tools, please let us know if you have questions on these 4 standardized outcome measures. Again, just to reiterate, moving forward, you should understand the basic constructs of each of these 4 tools. You should understand what the tool affords you and why you might select this type of tool, and understand some basic advantages and limitations for each of these measures. As you're reviewing